So welcome to another episode of Tell Us More About That. Today we have a really exciting guest. I think I say an exciting guest every week.
Well, they are exciting.
They all have been very exciting. This one is maybe the most removed, though. A lot of the guests so far I've had some connection to in some way. This one with Dr. John Walkup, I was listening to a podcast called the Psychiatry Boot Camp, which is amazing. He's like, you've done so many, I'm sure, so many interviews, but it was very well done. And the episodes they bring on people like our guest today, Dr. Walkup. But the episode I heard with him was all on anxiety disorders. So it was fascinating. It made me look at the topic in a completely different way. So I reached out to him right when I got back from the run, and he got back to me, which is amazing. So we have Dr. Walkup on today. Dr. Walkup, I can have you do a better job, I'm sure, introducing yourself.
Yeah, I'm John Walkup, and I'm a child and adolescent psychiatrist, and I'm chair of the Pritzker Department of Psychiatry and Behavioral Health at Lurie Children's Hospital of Chicago. I'm also president-elect of the American Academy of Child and Adolescent Psychiatry. I start my term in about 18 months, but wow. That's an organization of about, I think they're getting close to 11,000 members
wow.
from around the world of child and adolescent psychiatry.
Wow, that's huge.
Yeah,
it's big, but there's still not enough of us, as everyone knows.
Yeah, so it was just by happenstance that I decided to wear this Goose Island shirt this morning. Not really making the Chicago connection, but it does feel right now that we got a Chicago guest on.
Oh.
So we want to focus on anxiety, which I know anxiety can go in a lot of different directions. And to fill you in, a few weeks ago we had a guest on who was talking through all things OCD, and we got into a little bit of anxiety discussion on that interview as well. But today we really want to focus on providing an approachable understanding for what anxiety is, and if we have time, differentiating from your area of specialty, which is adolescents, children and adolescents, and then maybe talking about the dynamics between differences of adults, kids, how it presents, and Lord knows where we'll go over the next 50 minutes. But that's kind of the idea. Can you provide us with your kind of your boilerplate understanding or definition of what anxiety even is?
Yeah. So I'm going to take a step backwards, and I'm a medical person, right? So for every kind of happy, healthy, normal human function, there's a pathologic form. So for sight, there's blindness. For hearing, there's deafness. For smell, there's anosmia. So anxiety is a healthy human emotion, just like sadness is a healthy human emotion, just like happiness is a healthy human emotion. But I think it's important to understand that, at least from my perspective as a medical person, there are disorders of anxiety that are pathologic. Just like depression is a pathologic form of sadness, and mania is the pathologic form of happiness. Does that make sense?
Sure.
That does, yeah.
Right. So what differentiates normal, healthy anxiety from pathologic forms of anxiety? Normal, healthy anxiety is triggered by things that are relatively universal. So for kids taking a test, most kids are going to be anxious when they take a test. If they're well prepared, they're going to be less anxious. If they're not well prepared, they're going to be anxious during the test, after the test, waiting for the results to come back, and they're going to be uncomfortable. But it's all related to kind of preparation. So there are things in our environment that are universally anxiety provoking. And that kind of anxiety happens all across the lifespan. There is no kind of age of onset for anxiety. It can happen at any time. And so that's the nature of anxiety. It's part of a human emotion. Anxiety can be severe and persistent if the world in which the person lives is highly adverse. So, for example, kids in Gaza, Israel, Syria, Ukraine, Sudan, those kids are having a really hard time. If we gave them an anxiety disorder rating scale, they'd probably score pretty high on feeling anxious. Would I call that pathologic? No, I would say that's a normal reaction to extraordinarily horrible life circumstances.
Mm-hmm.
The anxiety disorders, what characterizes them as the triggers for those things are normative developmental experiences. So, for example, kids with separation anxiety, which starts between 6 and 9 years of age, something like that, those kids cannot tolerate being too distant from a caretaker. So they follow their parents around the house. They can't be in the bedroom alone. They like to have the door open. They like to have the parent with them as they're trying to fall asleep. They may show up in the parent's bed in the middle of the night because they can't tolerate being away from their parents.
I'm sure the parents love that.
Most kids want to be independent. They want to be able to separate in a developmentally appropriate way. These are kids who don't like to go to school. When they get to the school, they worry about bad things happening, so they go see the nurse. And they ask to go home so that they can be with their parent again. Most kids love being at school. As a matter of fact, they can hardly wait to get back to school sometimes in September. So if you think about separation anxiety, it is the inability to tolerate routine, normal developmental separations. Social anxiety. Most kids are extremely social. I mean, they are looking for buddies everywhere, looking for safe playmates, looking to have fun, looking to show off, show how smart they are to other people. So they raise their hand and ask questions. They love being in the front of the class. They like doing a little drama. They'll do a dance for the company when they come over to the house. They can hardly wait to learn how to order food in a restaurant so they can be autonomous. But kids with social anxiety, they won't raise their hand in the class. They won't make eye contact. They don't like going to parties. They don't like meeting new kids. All of those things are threatening to them because they feel humiliated if they goof up. And that's what social anxiety is. And then generalized anxiety, which is the third big one, that these all three of these start before puberty. Generalized anxiety, most of us can tolerate a fair amount of uncertainty in the world, like what's going to happen this evening, what's going to happen tomorrow at school, what's going to happen, this weekend, what are we going to do? But kids with generalized worry cannot tolerate those everyday uncertainties, so they ask a lot of questions like, what's going to happen today? Is the teacher going to be there? What are we going to do in class? What if this happens? What if that happens? Are you going to pick me up? What if you're late? What am I going to do if you're late from picking me up? All of that everyday uncertainty is the kind of thing that makes the generally anxious kids anxious, whereas most kids could care less. Recently had a very young kid worry about a Houthi rocket coming to Chicago.
Wow.
Right? So they heard that the Houthi rockets could get to Israel. Was a sensitive topic for the family, and he wondered, can those Houthi rockets actually get as far as Chicago? Most kids would hear about the Houthi rockets and care less. They'd be concerned, but they wouldn't make it an issue that would make conversation for sure, require reassurance from the parents. So those generally anxious kids are often perfectionistic. They're usually quite rigid. They don't tolerate any kind of uncertainty, so their rigidity helps them. They like things just so in a perfect kind of way. They oftentimes perform at the highest level because they're doing that out of fear or a sense of uncertainty. And so those are the three big anxiety disorders that hit kids, and they're qualitatively different than the normal healthy anxiety that we all can experience. During COVID-19, when people were saying 40% of kids have anxiety, what they were really talking about is maybe the 8 to 10% of kids who have these pathologic forms of anxiety. But when you take school away, you take friends away, you put your families in distress from economic, food, and housing insecurity, those kids are going to have an anxious reaction that is expectable, proportionate, and completely understandable. And again, if they were to complete an average everyday rating scale, they'd probably score pretty high. But I would never call those kids pathologic. Mm-hmm. They wouldn't get treatment like we treat for the anxiety disorders. So knowing that differentiation, because in the field we mish that stuff all up. We don't get really very clear about those kinds of differentiations, and so the field is very confused. And we get into fights about it. So, I don't ever want my kid to feel anxiety. It's like, if they're riding their bike on a busy street, you want them to be anxious.
It's a good human
emotion. To be careful. On the other hand, you want them to be able to separate. You want them to be able to engage in social activities, and you want them to not have to worry about the everyday uncertainties of life.
Interesting.
Yeah.
So if it's anchored to a rational fear, concern, something along those lines, that objectively people would be, a reasonable person would likely be nervous about it, that makes sense. Where it is a little confusing, then the purpose of kind of the rating system or the scale, if you take a snapshot and they take that, and then they would technically check the box of anxiety, what actually is the purpose of having that? If you still need contextually, you need like big picture to figure out what's really going on. Why even have them do that?
Well, this gets back to what's easy and what's hard. Just from a measurement point of view, most rating scales will have a cutoff threshold, for example, right? And some of them are tied to diagnostic criteria. So probably the most famous one is an instrument called the SCARED. SCARED has all these diagnostic criteria listed in it, and if you develop a certain score on a certain set of the symptoms, that indicates you have separation symptoms, or you have social anxiety symptoms, or you have kind of generalized worry symptoms. Some rating scales are much more diffuse. They just talk about worry that you can't control or that makes you uncomfortable. And on those rating scales, kids in the Ukraine, kids in Syria, kids in Gaza, kids in Israel, they're all going to rate high on those because they're uncomfortable because they live in horribly adverse life circumstances. So the other reason why we like rating scales is that, a kid with a score of 20 is worse than a kid with 15 and is worse than a kid with 10. So when you do statistical analyses, it's always nicer to have a range of scores rather than to have a yes and a no. Whereas when I'm talking about a condition, I'm talking about condition yes or condition no. As soon as you do that in your data analyses, you lose statistical power big time. So we love to have dimensional rating scales in science so that we can see that gradation, we can develop correlations, we can develop associations. And so a lot of our science is based on having these kind of dimensional views of all of the conditions. But the problem with dimensional views is just like I described, is that it lumps together normal anxious stuff with pathologic anxious stuff and doesn't help us differentiate among them very well.
Makes sense.
Yeah. So when you're diagnosing a child, is it just more like conceptual conversations you have from the quantitative information you're getting in, or how do you typically move through that?
So the anxiety disorders start between 6 and 12. So if I've got a referral for an 8-year-old, there's three conditions that they can be coming to see me about. Autism at the high functioning level is those kids present at age 8. ADHD can present at 6, 7, and 8 because that starts about the same time, a little bit earlier than the anxiety disorders. And the anxiety disorders start between 6 and 12. Major depression, you can see it in that very young age group, but it's much more common to start in the mid-teenage years. And bipolar disorder, you can see it in prepubertal children, but it's extremely rare, less than 1%, where it's closer to 1%, maybe 2% when you're talking about 16 to 25-year-olds. So we know when all of these conditions start. And so when I hear about an 8-year-old coming for a visit, I've narrowed my differential diagnosis down to 3. And when I hear he can't sleep and he's struggling and feeling flooded and overwhelmed and is not doing very well in school anymore, and the teacher wonders about ADHD, I'm like, no, not really. This is anxiety. And so a lot of what I do in my evaluation is this is what ADHD looks like. This is what separation anxiety looks like, which is what I just did with you guys. This is what social anxiety looks like. This is what generalized anxiety looks like. And the parents will say, I vote for number 2 and a little bit of number 3. And then I say, tell me about kind of how those things show up in day-to-day living. And then they do the narrative. And so I get the narrative from them. And then I said, well, what about this? And they said, oh, yeah, he does that too. And then what about this? And yeah, they got that one too. I hadn't thought about that. That might be part of it. And so we have this discussion. And more often than not, the family looks at me and said, were you at our house last night?
And you say, this is awkward, but yes, I was.
But if you get what I'm saying, I know these conditions so well.
Yeah.
And the evaluation isn't like, does your child have problems with separation? Does your child have problems with uncertainty? Does your child have problems with social situations? When I ask those questions, families don't really know why I'm asking those questions. Mm-hmm. So I teach them what I'm looking for. And families are pretty good at voting. They'll say a smidge of that, but not now. He had that more when he was 5 or 6. Okay, mm-hmm. So that's very common for people to say around separation anxiety. 5, 6, 7, they had that, but now they have more social and more generalized worry at 8, 9, and 10. So families are pretty good. Once you teach them about what you're looking for and why it's important, they'll fill in the blanks for you and they'll help you make that assessment.
Yeah.
So there's so many different things, and part of this is where we'll go here in a little bit, but it seems very almost impossible to provide a diagnosis of this child or this adult, whoever it is, has anxiety, and then with kind of blinders on, ignore all the other things that they probably have, tiny little bits of that present in different ways. It's not like saying you have the flu. You have anxiety and you have things that represent as maybe a little bit of ADHD, maybe some depression comes into play. It sounds like that's probably happening. It doesn't?
No. See, that's
interesting.
That's the thing. That's the problem with dimensionality, right? Because if you think about it, kids with anxiety who are worried about the missile coming from the Houthis, they're going to have a hard time sitting still in class and paying attention. So they will get called or misdiagnosed as having ADHD. And even some neuropsychologists can't sort out an anxious cause of inattention from a kind of a more ADHD cause of inattention, which is something we very commonly see with neuropsych testing in our community. People just don't know how to attribute anxiety as a cause for inattention. And if you think about it, most of the kids that I see with an anxiety disorder, I'm seeing them, it started between 6 and 12, and I may see them at 13 or 14. So they've spent 3 or 4 years living in an anxiety state. And at some point or another, they begin to bump into the capacity to continue to cope and function with that, and they begin to crumble. And what's happening at that time is they begin to get unhappy. They're not clinically depressed. They're demoralized by the fact that they have a condition that hasn't been recognized. Their family has been doing everything they possibly can to support them. And they may experience some inattention at school. They may be unhappy. And if you're just counting symptoms on a rating scale, they will meet criteria for anxiety, for ADHD, and for depression. But I don't do that anymore. Anxiety will cause you to have inattention, and anxiety over time, when it's untreated, will create a demoralization state that's pretty severe. We see kids get suicidal from demoralization related to having untreated anxiety.
So I didn't present what I was saying in the right way. What I was saying is what you just clarified of when somebody comes in and they are presenting all these different things, it can be easy to throw a dart and be like, you hit this one, you hit this one, you hit this one. But in reality, what you're saying is more, you're doing actual root cause analysis for the patient to figure out what started all of these things, and then addressing that causal symptom. That's interesting.
Yeah, I mean,
go ahead.
Go ahead. Well, if you live in a constant state of, or a chronic state of anxiety or stress, you will start to feel those like more sad, uncomfortable, discouraged feelings. And if yes, we're going to like radiate out to other symptoms and maybe not clinically diagnosable, but to other symptoms of problematic experiences. I could absolutely see that.
So kids with anxiety, their dominant coping strategy is avoidance. So if
So
you're
is mine.
so if you think about it, let's say you have social anxiety at age 5, 6, 7, and you avoid social situations. What's the implication of that for your growth and development? One, you're going to be soft spoken. You're not going to make eye contact, and you're going to avoid peer relationships where you may be uncomfortable. So if you do that for 4 or 5 years, your language won't develop, your social competencies won't develop, and your ability to kind of transition to independent kind of relationship development won't happen either. So what you begin to see with kids over time is they develop poor adaptation and coping, poor language, poor social skills. And again, if you don't have a sophisticated diagnostician, if they're just looking at simple cross-section, they'll say this kid's got a language disorder, this kid's got social stuff, social skills deficits. They won't really look at that root cause analysis, which is what you're describing. Most of our diagnostic schema are cross-sectional. We just look at a kid in time, right? Mm-hmm. One point in time, and we count the symptoms that they say yes to at one point in time. Well, if you do that, you don't really see how symptoms evolve over time. And for the anxiety disorders, there's a clear pattern of evolution over time. So the 16 and 17-year-old with an never treated for anxiety disorder, they get flooded and overwhelmed. They break down, they regress. Some of them realize that, particularly if they have generalized worry and social anxiety, they oftentimes realize that they're funny and lively when they drink alcohol, so they begin to develop a substance abuse problem. They will get diagnosed as having late onset attention deficit because they won't be able to cope with the massive amount of homework that they get in high school or later in college. So they'll get an ADHD diagnosis. And so part of what we do in a really good diagnostic frame is to dismantle those presentations when people are coming at you with all different kind of stuff that they've learned about on the internet. What we try to do is say, listen, you're one person, you probably have one disorder, but that one disorder has implications for how you grow and develop and cope. People interact with their condition. They try and figure out why they're sad. They try and figure out why they're anxious. They try to come up with explanations. And in the mental health field, there's millions of explanations, and there's millions of therapists who are willing to give you an explanation for why you feel the way you do. But very few people do the longitudinal look from a disorder base. They'll do longitudinal from attachment. Like, you had this thing with your mama or your daddy when you were younger. So we'll do longitudinal that way. But we very infrequently talk about courses of illness in psychiatric disorders and the implications. We do that with diabetes. So if you have uncontrolled diabetes, you're going to get kidney problems, you're going to get vision problems, you're going to get vascular problems. That's the complication of untreated diabetes. But we don't necessarily do that very well with psychiatric stuff. So we do cross-sections. And cross-sections lead to rating scales, and rating scales will allow you to have 5 or 6 different diagnoses because inattention is part of ADHD, it's part of anxiety, it's part of depression, it's part of psychosis. Doesn't help much when you say I can't pay attention. It doesn't lead you there very frequently. So this is why a lot of people get confused in the mental health field, is because there isn't this sifting and sorting inherent to what it is we do diagnostically.
Is this a foundational part of the educational system for practitioners where they're, what you just said, like talking about really getting to root cause analysis and a longitudinal understanding of the individual's condition versus just a snapshot, diagnose, medicate, or otherwise and move on? Why does the latter seem to be the more common thing versus what you're explaining, which seems to make so much more sense?
Well, I think there's two kind of pathways, if you will. adult psychiatrists, they see the kind of full form of a condition, right? So they see a bad depression. And the sensitive, smart ones look back in time for where it may have developed, right? Child-oriented mental health professionals start with attachment problems and they work their way up through attachment to all the kinds of difficulties that you can have from disrupted attachments, trauma, and whatever. What's interesting is that those two pathways of psychopathology, bottom up and top down, never meet each other because there is no attachment etiology for schizophrenia, right? So there's a biological cause, but we have not really come together where our kind of early life experience maps onto and connects to what we know about the onset of these conditions in childhood and adolescence and young adulthood. So we oftentimes speak in directions that don't map onto each other. The other thing is that there are some people who hate diagnoses. They think it's labeling, and they think it's bad to label because giving a kid a diagnostic label means that they'll behave more poorly or that they'll embrace the label and function less well once you label them. So on the other hand, you have a kid who's got a problem and you give it a label and they say, that's what it is. What do I do to fix it? And you tell them how to fix it. And they get better. They say, that's the best thing that ever happened to me. I have a label for my condition and I've got a great treatment and I'm in great shape now because I got a diagnosis and I got the treatment that's appropriate for me. So we also have those kinds of conflicts in the field. So there's all kinds of stuff that makes it really hard for families to understand what it is we're doing in the mental health space. And people are trained in one of these modalities or another, right? So, and that we're not all trained in the same set of theoretical backgrounds or theoretical approaches to diagnosis. So some people get this attachment thing. Some people get schizophrenia in 16-year-olds because they train in adulthood. Some people don't like using diagnoses. Some people have a trauma focus that is, a singular etiology that explains everything that's bad that ever has happened to any human being. So, people are trained in all of these different models, and it's part of the problem of our field is that there isn't a single model that is used and usable. And so families get confused, and sometimes people don't get the care they need.
I also think that practitioners get confused. So I spent a little over a year, almost a year and a half, as in a private practice as a therapist, and I had these little snippets of training of different modalities, but I was never, and I'm not fully licensed in Illinois, but I was never fully trained in any one modality. And so I was like, okay, well, this kind of sounds like DBT might be good, or right, and I'm ACT maybe. I'm like, I don't know. So it's even as a practitioner, it was so hard for me to say. And part of me loves that you have all these different options to choose from. And then I never felt fully competent or fully trained in any one of them to really lean into it and say, I think this is your best bet here. And I totally agree with the diagnosis part of, insurance loves labels and they love diagnoses. And there were so many times that I would say, I'll call this an adjustment disorder, but it makes perfect sense that you're adjusting in this way. And it makes perfect sense that you're responding in this way. And so I think even as a practitioner, it's so hard on that front to narrow down your own approach and how you interact with diagnoses in patients.
Yeah. So I think that what we started with is that, human beings do many things that are have many capacities, and there are pathologic forms to every one of them. Mm-hmm. So that idea that there's IQ and intelligence, well, there's dementing conditions, and there's subintelligence or intellectual deficits. So for every kind of thing that's human, that is happy, normal, appropriate, developmentally spot on, we have a pathologic form of that. And sometimes it's dimensional, like dyslexia is very dimensional. There's people who are severely dyslexic and people who don't have any dyslexia, but there's lots of things in between. So that's a truly dimensional thing. Personality traits are often very dimensional, like introversion or extroversion or the capacity to which you're rigid or unstable. Those things have some dimensionality to it. So we do dimensional stuff in this field, um, but but using only dimensional stuff in this field is probably not the right idea, because there are some real honest to goodness conditions out there that once you identify them, we have evidence-based treatments for them, and the treatments work pretty well. But if you're stuck in a dimensional world and you don't think about categories, you're not going to be able to offer those kinds of assessments and treatments to patients.
Yeah. So if we're talking childhood anxiety, whether it's separation or social anxiety or generalized, what are some of the treatment modalities that are kind of most research based and effective?
Yeah. So, it's all in the cognitive behavioral realm. So, with kids with separation, what you do with those kids is you do progressive desensitization, which is little itty bitty separations here and there. Um, One of the things that families of kids with separation anxiety do is they have big goodbyes and big hellos. So, before they separate, it's like, you're going to be okay, you're going to be okay, you're going to be okay. And then when they come back from a separation, it's a big hug. So what we try to do with separations is make
That's how I am with my cat, unfortunately.
we make them highly frequent and low emotion expression, right? Bye, good to see you, back, kind of to try and get kids to desensitize. The kids who don't go to school, you drive by the school. You drive by the school and you park. Drive by the school, you park. You get out of the car. You drive by the school, you park. You get out of the car, you walk to the door. And you progressively desensitize the kids. And that's cognitive behavioral therapy. It's got a lot of behavioral stuff in it. Social anxiety, you got to go do social tasks. So, you write down the most complicated order to take to a coffee place, a mocha with the almond milk with the twist and an extra shot and whatever. And you kind of hope that the person who's doing that with the barista says, can you repeat that? That's what helps people with social anxiety get better, is put them in situations where people are going to be confused by them, not understand them. Or where they have to compliment a stranger on the street or something like that, which they would ordinarily be loath to do. They go out and they do those exercises and they realize that it's okay to say, boy, that's a nice looking jacket you've got on, or, I really appreciate that tie you're wearing today. And, getting past all of that kind of stuff is what you do with social anxiety. Generalized worry is tougher because those kids sit in their head.
Mm-hmm.
And they're thinking about the hooties and the missiles, and they're thinking about what's going to happen next. And the logical thing to do with them is to provide reassurance when they say, what's going to happen, what's going to happen, what's going to happen. But that reassurance functionally rewards them for being uncertain.
Mm-hmm.
So a lot of what we do with those kids is we try and kind of put them in a predictable world, and then really get them to internalize self-talk about those uncertainties. So, you've asked about the Houthi missiles like 4 times now, and I've told you there's no chance that the missiles will fly that far to Chicago. So you just asked me about the Houthi missiles. What's my answer going to be? Your answer is going to be they can't come to Chicago. Okay. So the next time you're wondering about the Houthi missiles, don't say the question out loud. Say it to yourself, and then use the answer that I just gave you and say it to yourself, and then get on with your homework. So what we do over time with some of that reassurance seeking from those kids who are worriers is we get them to internalize the worry and internalize the self-talk. So it's not so much an exposure per se as it is getting them to kind of answer their own question and keep it internal and take it out of that interactive frame.
Yeah.
And then a lot of it is, with the anxiety disorders, a lot of it's just function. So not going to the nurse, going to school, sitting in class all day, raising your hand, ordering food in a restaurant, going to the party that you don't want to go to. A lot of it is that kind of stuff that really focuses on function. And modern moms and dads, and even many therapists, are very empathic for their kids suffering. And so what they tend to do is they accommodate and kind of provide permission for kids to avoid and not cope. And so what that does is it's the dark side of parenting around anxiety disorders, because that makes stuff worse and worse over time.
Yeah.
There's a guy named Eli Leibowitz who you might want to have on. All he does, he never sees the kid. He just trains parents how to stop accommodating.
Oh, I love that.
That is great. Yeah.
That's really cool. And
That's
that's a whole new thing with therapy nowadays. So,
Parent
there was the
coaching.
one suicide in borderline personality, chronic suicidality and self-injury study that was done where they did DBT, and DBT training of parents worked better than DBT training of the kids.
No way.
That's
Wow.
right. So again, if you think about it, if you have a parent who's raising their kid 24/7, 365 and using really good principles, that's much better than a kid going to therapy once or twice a week. So you're beginning to see in our field a move away from that one-on-one individual therapy thing with younger people, which much stronger focus on parent interventions. And some like with the anxiety, with the SPACE program, almost exclusively work with the parents, no work with the young person.
Wow. I've seen that there are other clinicians, not in Illinois, I don't think, but that if they're working with a child or a teen, they require that child or that teen's parent or parents are also in their own sort of coaching or therapy. And that makes so much sense to me.
Yeah. I'm a parsimonious clinician, so I do it all.
Yeah.
There are some who kind of try and protect the relationship with the child from contamination. And I think sometimes what happens with that is you don't really leverage the opportunity of the relationship. So I tend to work with everybody in the room together, and I'm much more interested in the interaction among them than my interaction with them.
Sure.
Yeah.
Are you finding that I really liked what you had said about what do we call it? Progressive desensitization. Is that how we're framing exposure therapy now?
Mm-hmm.
Okay. Love that. But I'm wondering too, how many parents are willing to be that consistent and slow moving? I feel like by the time they show up at your doorstep, they're like, I've had enough. I don't know what to do here. What's going on? And they're looking for a quick fix. So how many of them are willing to do that progressive?
Well, what's really interesting, there's a study called the Child Adolescent Anxiety Multimodal Study that we published in 2008. And when you look at some of the kind of subsequent papers from the original paper, families all want cognitive behavioral therapy. That's what they want. They do not want to use meds. But the remission rate at 12 weeks for cognitive behavioral therapy was 35%.
Okay.
The remission rate, this is gone. This is symptoms gone. The remission rate at 12 weeks for a combination of med and psychotherapy was 65%, a 30-point difference.
Wow.
That's a huge difference.
Yeah.
Even at 24 weeks, the cognitive behavioral therapy improved to 45%. So you had a 20-point difference. So parents really don't know how valuable it is to do combined treatment or to add med as the first treatment. The other thing that's interesting from that study is that the 65% of kids in psychotherapy, high quality psychotherapy, this is UCLA and NYU and Columbia, Hopkins. This wasn't sleepy CBT. Phil Kendall at Temple. This was great CBT. The 65% who didn't remit didn't add med, even though they had the opportunity to add med. So the ones who did, this very small percentage of kids who added med got better. But there's something about doing a treatment, and if it works, that's great. But if it doesn't work and you've made a big commitment to it, families aren't necessarily saying, what's the next step then to get better? They kind of said, well, I guess I've gone as far as I'm going to go, and they peel off and don't engage in treatment. So one of the problems, I think, for community-based therapists is if they're doing start low, go slow, doing a kind of supportive intervention, you do that for 12 weeks, you make an investment in that, you haven't made a lot of change. That doesn't motivate people to go get more treatment. That essentially says treatment's not worthwhile. And so we're seeing people who smolder in terms of symptoms over time because they do treatments that are not very intensive, not very dramatic in terms of their implementation. And as a result of that, they don't work very well. And with that, they peel off and they don't continue to pursue care, and then they become chronic and impaired. And so that's what we see in teenage years is lots of kids who tried things, but because it didn't work the first time, they've kind of lost hope for anything working for them.
Interesting.
So a lot of what I do for those kids is to remoralize them and get them excited about being in treatment again, because I can offer some hope and do some stuff that's effective.
In that study, was there any finding of the population that had CBT without medication versus the combined group? Is there anything that you could look at those two groups and then predict or flag the medication worked for these people because they met these conditions? This group didn't need medication because they didn't have these things. Were there any takeaways there?
Yeah, those are moderators of treatment outcome, right? So when you have a response rate like 65%, that's robust to any moderator usually.
Yeah.
When you have a response rate of 35%, what you've got is kids who are less ill, younger, symptomatic. They've been symptomatic for a shorter period of time. All of those are the kinds of things that are going to work for kids. They have a simple set of symptoms, and those kids tend to do better with psychotherapy. Doesn't mean you can't treat a teenager, but think about it. If you have a teenager with anxiety symptoms, they're 16 and their anxiety disorder started at age 7, they have 9 years of accumulated impairment. So you can get rid of their anxiety disorder symptoms with CBT, but they will have accumulated a lot of the sequelae of avoidance behavior, parental accommodation. They may have started thinking about suicide and cutting on themselves. They may have started drinking a little bit of alcohol in social situations as a way to feel better. Those kids, their anxiety disorder may get better with anxiety disorder treatment, but they don't know how to live, and they've already developed some maladaptive coping strategies. So it's sometimes harder for clinicians to see that group getting better because they just focus on anxiety disorder treatment because they see it as a significant component, but they don't do the rehabilitation work that is required to take someone who's lost 8 or 9 years of their life to teach them how to live again and how to cope and how to not use maladaptive strategies like alcohol or self-injury.
Yeah.
So I usually think in 3 levels of treatment: symptom treatment, accumulated impairment treatment, and maladaptive behavior treatment for those kids who have had a condition for an extended period of time. And this is true for ADHD. So, ADHD starts at 6 or 7, but you're seeing a 17-year-old, they will have accumulated impairment in terms of their belief about their intelligence, about their capacity to work hard. They'll have disruptive relationships because they've been impulsive. They may have used alcohol. So you can treat their ADHD with a stimulant, but you still may have accumulated impairment and maladaptive coping strategies that you have to deal with that 17 and 18-year-olds who's had poorly treated ADHD.
Yeah.
So that pattern of accumulated impairment and that pathway to maladaptive behavior happens pretty much for all conditions.
Okay, that makes sense. I want to touch one more thing on the medication real quick. So first off, for anxiety in kids, what is the most effective treatment that you've seen from a medication perspective? And then the second part of that question is, why are parents so against it? So what are the scenarios where is it just myths and what they're hearing in the media, or are there long-term negative potential high likelihood side effects that they're trying to avoid?
Yeah, it's a great question. So the medicines are really the SSRIs, so the fluoxetines, the sertralines, the escitalopram. Two of them are approved. Escitalopram is approved down to age 7, and duloxetine, which is a SNRI, serotonin and norepinephrine reuptake inhibitor, both of those are approved. I think the press, there's a lot of people who hate medicine, and it's a complicated group of folks. There are people who hate pharma, so kind of left-leaning people who hate corporate America, if you will. They hate pharma and drug companies and drug advertising, and they believe that the advertisers have the power to kind of corrupt the population. And then you see people on the right who are don't really believe in mental illness, have kind of religious orientation. So there's this kind of complicated alliance of politics, if you will. Folks in the middle, they said, give me a solution. I got to get back to work.
For the love of God, fix this so I can go do something else.
So, and what I say to people is, listen, I don't want to medicate your kid either, but you don't know what I know about how medicines work. And all I'm really asking for you is 12 weeks to let me show you. And at the end of 12 weeks, you can decide whether you want to keep it going or not. But it's going to take 12 weeks to get you there and to see what it is that I know we can do for your kid's anxiety symptom.
Well,
and I've had families say, well, he got really a lot better, but I don't like it and I want to get rid of it. And I say, absolutely, I'll get rid of it. But at least now you know what I know.
Yeah.
And then when the symptoms come back, they kind of bang on my door and they say, can we go back up again? And how long are we going to have to do this? And so I always tell families, I'm the person who puts you on, and I'm going to be the person who takes you off. And so I have a plan for discontinuation on the day I start. And that makes it a lot easier for families to start if they know that at some point or another I'm going to take them off.
Absolutely.
So even that, even which that was an incredibly enlightening explanation there, but even the way that it was introduced, there's still a negative connotation and association with medication. Like even saying like, I don't want to medicate your kid and I have a plan to get you off the medication, it's all implying they shouldn't be on it in the first place, or there could be some negative impacts for being on it. So where is that even coming from?
So a lot of it comes from the fact that once a kid puts one pill in their mouth, everything that happens in their life after that is my responsibility. Psychotherapists don't share that responsibility, right? So, if they took a pill today and they fall off their bike, well, they fell off their bike because they took a pill today. If the kid falls off his bike after seeing his therapist, nobody's going to say, he fell off the bike because he had a bad session with his therapist. They just don't make those kinds of connections, right? But families make those kind of connections. It takes a lot of work to medicate a kid. Again, anxiety starts between 6 and 12. We're medicating 7-year-olds, 8-year-olds, 9-year-olds. Families are extremely sensitive. There are side effects, and there are some kids who don't tolerate these medicines at all. But we can manage 99.9% of those. The other thing that some families are concerned about is if we start it today, how long will he have to be on? And there are clinicians who say for the rest of his life, and there are some families who say, then I'm not going to start. And I'm like, well, you understand that doesn't make any sense. One, the rest of his life doesn't make any sense, and not starting because he may have to be on it the rest. None of that makes sense either. So there's ways to talk with families that kind of help them get over some of that resistance. And that's why I talk about a 12-week trial. The choice is always theirs. They need to learn what it is that I know about how medicine can be effective. I also say that the medicines have to be like drinking water. There cannot be any day-to-day effect of the medicine on your child that is visible or discernible. It has to be so clean and simple. You just have to see benefit. Some families believe that the medicines kind of change consciousness in some respects, and what they really do is they just lift the burden of anxiety. So I describe the outcome is, if you look at your kid's very best day over the past month or two, it's going to look like that day in and day out. They will be themselves, and they will look like they're having their best day every day. And as a matter of fact, when kids get better on medicine, you see this unleashing of this developmental locomotive that is just driving into the future. The anxiety disorders are really impairing and hold kids back. And when that anxiety is gone, they are free, sometimes a little too free. So kids who have separation stuff want to go to school. Their families have been protecting them and staying at home, and now all of a sudden they want to go to the playground and they want to do a sleepover, and the families are just not ready for all of that change over a 4 to 6 week period. So you do see some families who really cope with that kind of abrupt change in functioning and behavior. But I tell them to chill and deal, because this is what childhood looks like, man. It's when these medicines work and these kids are better, they want to live life like every other kid wants to live life. So more power to them.
It made me a little bit emotional imagining like the freedom that those kids or adults when they first, tune into the medication feel.
Yeah.
Well, sometimes
I love that.
One of the things I do for families is I take a look at kind of emotion regulation capacity within the family. And I also look at kind of where they are in terms of rules and regs and kind of moral values and stuff. Because sometimes if the kid isn't been raised in a positive emotion regulating environment, or if the family values aren't all that great, sometimes when they wake up from this stuff, from these anxiety or depressive disorders, they begin to do things that are untoward. Mm-hmm. So perhaps a little bit more with depression. When kids get better with depression, they'll get better in 6 to 8 weeks. And so most of them have been isolated and withdrawn for an extended period of time. So they try and join a peer group. But you and I know the only peer group that is always accepting new members is not a great peer group. To get
not
into
at that
those,
age. Yeah.
Not at that age. The high functioning peer groups have a high bar for membership.
Yeah.
So what happens is those kids come out of their depressive episode. They join the peer group that's always accepting new membership. Those kids have other kids with depression. They use substances. There's boys and girls there. They fall in love. They get their heart broken. They smoke marijuana. They go home to their parents. The parents smell that stuff. The parents kind of come down pretty hard because they're kind of not used to dealing with a youngster who's got new freedom. For me, that's the suicidality that's part of depression treatment. It's because the improvements in mood and energy happen so much faster than the improvements in cognition and capacity. And so what you see kids doing is they get out there, and when they start interacting, I've had kids who've said to their parents, listen, I'm 17. I've had this depressive disorder for 4 years. Why did it take you so long to get me treated? And I've also had kids who said to their parents, my therapist tells me your marriage really stinks, and I think you guys need to go into some therapy. Well, I've had parents tell me, I want you to take my kid off medicine.
Jeez.
Because he's too much to handle. And I don't really want to do that. What I want to do is I want to say, listen, you guys are in some rough shape because you didn't do all the early work you needed to do around emotion regulation. Your values are a little suspect as a family, and you got some work to do to get your kid back in line again. So there are things like that happen that I call complications of treatment. They're not really even side effects, but they're complications of kid getting back really quickly and their family just not being prepared to be able to manage it.
Yeah. Well, and that's where your relationship building with the entire family system rather than just the one child comes into play.
And I can tell pretty much those families that are really struggling with kind of raising their kid in general. And there are some kids who are really smart, really clever, and they're going to give their parents a hard time when they're better. And so I warn the parents about their need to kind of get their stuff together to be able to handle the horsepower that comes out of this when kids get better.
Yeah.
How difficult is it for kids to be as kind of dialed into their own emotional regulation and well-being could you have the same conversation with the kid, like a 9-year-old, and tell them, hey, listen, here's what's going to happen once you get off and you start to feel better. When you go back to school, you're going to want to socialize, and kind of give them a little bit of a roadmap. Are they pretty receptive to that?
Yeah, I do that all the time. And there's
That's so
another
cool.
group of kids. These are the kids who live, I call them white knucklers. You know, their moods have been so out of control for so long, their anxiety is so out of control that they've kind of lived like this.
Mm-hmm.
And when they start feeling that mood come back or that anxiety go down, it is a threat to them. They are really, really uncomfortable because they've been hanging on to their moods for a long time. Those kids really struggle with recognizing that they have some freedom, recognizing that their mood is better, beginning to loosen up a little bit because they're afraid that any change in mood that they've got is going to go away. It's not going to be persistent for them. So those kids need a lot of additional support to kind of let that mood happen, let themselves grow into their mood, not hang on too tight to those negative kind of sets and cognitions, not white knuckle it so much, but to kind of get comfortable with the idea that they can be happy and that they can enjoy themselves and things aren't as scary as they used to be. So there's that group of kids too who bring that kind of temperament to their condition, and it becomes part of what you work on in treatment.
Dr. Walkup, I know I want to be mindful of your theater tickets. I have one remaining question that I think could be its own
I'm
podcast episode.
You guys are good. You guys are good. I mean,
you are fantastic.
This is awesome.
Stuff that isn't in textbooks.
Yeah, I think I have anxiety now. I'm curious, do you believe in, or what are your thoughts about birth order and the characteristics you've explained for anxiety?
I was not expecting that question.
I was not expecting that question either. I was expecting something about bipolar disorder, maybe.
You can go there too.
So birth order, I love all the kind of pseudosciences out there.
Mm-hmm.
I love birth order stuff, and you can get me excited about anything that tries to teach us some lesson about who human beings are and what they're about and some kind of explanation. So I'm not. These conditions hit every person in whatever birth order. On the other hand, I think there is something to firstborns. And if there's a big gap between the first and secondborn, the secondborn can kind of function like a firstborn. And I think the middle child always struggles a little bit. And so and there's families who put that stuff on the table, and I go, I'm with you. Because some of it is the narrative that families have come to write for themselves. And if it impairs their treatment engagement or impairs their capacity to recover, I'll help them rewrite that narrative. It ain't about birth order. But if they're having fun with the birth order and explain stuff,
go with it.
Go with it.
Whatever.
And I say, one of the things that's helpful to me is like, who in the family is this kid like?
Yeah.
And then they often roll their eyes, and they'll talk about the relative, and so we have most families are smiling by the time they're done with our evaluation, because we take their experience and we make it clear to them where they've been, what they've been experiencing, what they've been feeling, and we offer the hope of really good treatments, as long as they kind of engage and work hard. We get great outcomes.
Fantastic. Yeah. Thank you.
So I guess to finish this off, you had mentioned the different schools of training and practice within the field of mental health. With your approach of having kind of a totality, understanding the full person, not a snapshot in time, what would you label or identify that school of training or kind of approach to be? And if I'm a parent listening to this and I want someone who's going to evaluate my kid, my home life, and the big picture to really be with us on that journey, what type of practitioner should I be looking for?
Yeah, I think almost any practitioner can do that whole child thing. I think there are practitioners, I think medical practitioners tend to like diagnoses a little bit more than non-medical clinicians do. They'll tend to they'll tend to go to diagnoses more quickly, for good or for bad, because I think you gave an example of, you come in, you do a rating scale, you get a diagnosis, and you get a prescription all within 5 to 10 minutes. That's not what I'm talking about. I'm really talking about coming to terms with everything about the child that the family is concerned about, and then creating a description of who the child is, the kinds of problems they have. And in some respects, the longitudinal course, like the kid is 10, but this started at age 6, and some level beginning to also take that narrative and predict it into the future. There is something about that I think is very medical. And there are many providers in the mental health field who really hate the medical model, but there is something about the medical model that does this. So if I have a real concern about a kid or a family, you can go see anybody, but at some point or another, you may have to really go from one discipline to the next in order to kind of understand, get a fuller understanding of your kid, because we all have blinders to some aspects of it. People will say, I have blinders to trauma. I don't have blinders to trauma. I just appreciate that a kid who has separation anxiety and been traumatized has an extra complicated kind of thing, but it doesn't mean he doesn't have separation anxiety. So that kind of explanation doesn't work for some people. And so, I'm a physician. What can I say? I've been making diagnoses. I believe there's biology to these things, serious biology to these things. I think there's genetics to this stuff. The fact that a parent is anxious and a kid is anxious, it's not simply contagion.
Right.
It could be genetics. And I think sometimes most mental health professionals operate off empathy, and they look at things in a sequence, not quite like I look at them in a sequence, but they look at this happened, then this is the result. This happened, this is the result. And they create an empathic narrative. And sometimes that empathic narrative just doesn't formulate well and doesn't take people across the finish line where they need to get.
Mm.
Absolutely.
And if you think about it, all of our evidence-based treatments are based on diagnoses.
Yeah.
ADHD is based on a diagnosis, anxiety is based, OCD, depression, bipolar, it's all based on diagnoses. It's not based on dimensional stuff.
Yeah, it's funny because when you were walking through those examples of understanding the full kind of context of what this kid or person is going through, a few years back, I was going through, without question, the most stressful time in my life, and a lot of different things going on that I was juggling, and I was finding I was having a hard time sleeping, and I was having a hard time focusing on tasks. And I talked to my general practitioner about it, and she brings in a worksheet. She has me fill it out, and I filled it out real quick, and she said, "Oh, you have ADHD," and prescribed me medication. Just on that one thing alone. And the wild thing about it is, like, from what you're saying, it makes sense that I was feeling all those things. It's not necessarily a diagnosis. It's a response to
An experience.
a rational experience. Yeah.
Well, but on the other hand, I've treated 19, 20, 21-year-olds who have failed out of college, and they had ADHD for their entire life. And their parents never wanted to treat them, and so we started treatment when they were in college, and it treated their ADHD, and they started getting good grades, and they started feeling like a success. So it's not unusual for people to live with these conditions for a really, really long time, and essentially normalize the problematic behavior as part of who they are, or part of their temperament or personality. The other thing that I think is interesting about primary care is that short, quick kind of evaluation leads to a process of what I call systematic overprescribing.
Yeah.
But what I know is, because most people don't want to be on medicine, and most people will take that diagnosis and think about it, and the people where the medicine actually works, those people will continue the medicine and get a refill. The people who say, man, that's just life. Man, I was having a hard time with life. I don't have ADHD. Those people will discontinue, rightly so. but your primary care doc did you a real benefit by giving you an opportunity to think about whether ADHD was a lifelong thing, was something that was part of you in a particular way. And then you made a decision about whether it was relevant to you or not. And I don't know what you did, but if you discontinued, you decided that wasn't the right diagnosis for you. But many people, if you look at the data, there are many people who discontinue medicines within the first 30 days. And then what you see is this very long pathway of refills in a core population who come back to treatment.
Interesting.
Because that quick and dirty thing got them better over the first 30 days. And from my point of view, that's not too bad when you have 20% of people with a mental health problem. You've got to do some kind of systematic strategy for diagnosis and treatment that gives everybody the opportunity to come to terms with it.
The wide net. I like that explanation of it, actually. That particular prescription sat without being touched for a year, and then it expired. And that's a lot of that is just me being stubborn of like, I don't think I want this, because then it felt like it was like, I was going through grad school at the time and it felt like it was cheating, and so it's just more of a mental moral thing for me. But yeah.
Well, the question I ask of the older young people, I said, well, what happened when you stole your roommate's Adderall or methylphenidate? Kind of how did that work for you? And it's like, wow, that was really good.
Yeah. Like the best day of my life.
Yeah.
That happens in people who don't have ADHD. But if you have that history going back to age 6 or 7 where they had ADHD and that they had tutors and all kinds of stuff, all kind of accommodation to kind of keep them going, and then they finally treat themselves as a young adult, that's not such a bad story.
Yeah.
And it's not an uncommon one either.
Thank you. We appreciate your time and going over a little bit. I hope you're not
No, it's good. It's good. I got to grab a bite to eat and then get to the theater.
All right. Well, thank you so much. You were
this
incredible.
Was fun, guys. You asked great questions.
Awesome.
I hope your viewers kind of learned something from this, because again, this is there's no time in most sessions to talk like this.
Thanks for joining us on another episode of Tell Us More About That. Don't forget to subscribe on whatever platform it is that you're listening to us on, and also leave us a rating and review.
If you have any topics you would like us to consider, if you have any feedback or commentary, only if it's positive, please visit www.tellusmoreaboutthat.com.
Thanks again for joining in, and we will see you next time.
See ya.